Hello, thank you very much for this kind introduction. My name is Anja Weißenfels, and I am preparing my PhD at the University of Erlangen in the research group of Professor Dr. Kemmler. And over the last 2 days, you were able to listen to Professor Dr. Kemmler. Today, I will focus on chronical and unspecific back pain. At our institute, we work a lot with novel training technologies, and this is why I will also include the term whole body vibration, but we will focus for this matter on whole body EMS. Briefly on the background for this study, because EMS will be covered for orthopedic disorders a little later. Then I will talk about the study plan. I will describe the methods of the various phases, both the meta-analysis and the actual trials. And I will conclude and present an outlook. The study has not been completed yet, and this is why we have these phases that I want to walk you through. On the background of this study, the colleague before me, the presenter, asked about back pain. Almost everyone has suffered once in a while from back pain. So the prevalence at 74 to 85% is very high. In your family and friends, everyone will have suffered from back pain once in a lifetime. In 80% of these cases, this is an unspecific back pain. You go to your doctor, you ask the doctor, what's wrong with me? Doctors can't find anything. You sit a lot, you move wrongly, you have a poor posture, so there's no clear diagnosis. And this is when we speak of unspecific back pain. This has to do with the fact that we're very much on sitting and standing, which is very one-sided. So there are muscular disbalances. Our vertebral column is not optimally stabilized. In current studies, we can show that particularly strengthening and stabilizing training methods in the conventional area can reduce pain intensity and pain frequency, and also for unspecific back pain. And this is exactly where the new training technologies come in, such as EMS or vibration. Why? The main reason why people don't do sports on a regular basis is time. This is the main factor. 1 in 2 people will tell you, I have no time to train after work. 1 week, 3 times a week is simply too much for many people. With these two training types, the big benefit is that it only takes 15 to 20 minutes once a week. So it is ideally suited for this clientele. And how far does EMS and back pain correlate? First of all, I have this term of kinesiophobia. It is a fear of moving. You know, when you suffer from a type of pain, then you try to actually adopt a posture where you don't suffer any pain. You stand differently, you sit differently, but you don't move. Most types of sports require you to change posture all of the time. You have to sit, you have to lie down, so you actually have to adopt postures that are very painful. In EMS and vibration, you can do everything standing up. So you actually exercise light, dynamic movements and exercises that actually are perceived as joint saving and don't cause a lot of stress. The main aim of EMS is strengthening the core, the so-called core stability. And this is exactly what back pain patients need. They have little muscles around the back, and they have little tension in the back. Then we have assumed so far that this stimulation reaches even deeper muscle layers, so it stimulates the local back muscles. But we don't have a study available for this yet. We would have to do muscle biopsies in order to really find out how deep we can go with EMS. We have only been able to look at animal studies so far. what another big benefit? Well, I see back pain patients several times a week, and I have to actually walk them through a back program. You do a squat, then you actually have to tell them that they actually put the belly and the back under tension. Most people stand like this. They stand like a duck, and they don't even know what to do. So this whole body tension, this belly curl is very hard to teach people who actually have a lack of their body awareness and who are not very active. With power and electricity, you can actually induce this passively. You can apply it to the people. So when the power comes from the outside, then a normal person will actually be under tension to protect themselves. So you can use passive structures to stimulate the effect you want to produce. Then, last but not least, you can actually stimulate both agonists and antagonists at the same time. The belly and the back can be stimulated at the same time. So this prevents muscular disbalances that are often caused by conventional trainings and workouts. What I'm going to show you now is a study complex that covers 2 years, and it is done together with the Cologne Sport University. So this is a multi-center study supported by the DFG, the German Research Society, and it takes place in various phases. Why? First of all, we cannot train that many people at the same time, and when it is about pain, there is a subjective element. The number of subjects you require is really decisive to produce results. So you whenever you've reached the power, you can actually stop and go to the next phase. The University of Erlangen and the Cologne Sport University are listed here separately. We've started with a meta-analysis of internal data. Why? Because we said, well, do EMS and back pain go together? Does it make sense to do some research in this field? If EMS had no effect whatsoever, then of course consecutive studies would not have made any sense. But as it looked quite promising, we started with the first phase. Every intervention looks the same, is identical, and it is 12 weeks long. So there's no difference between the phases. What is special about the phase number 1? There was a passive control group added, simply because in science you can only produce exact results if you've got a group that has undergone some exercises and another control group that has not undergone any training. In the phase 2, this passive control group was skipped, like in phase 3. And we are now starting towards the end of next week with phase 3, and 45 new people will be generated as training subjects. So this is why I can only present the results of phase 2. In phase 3, the Cologne Sport University will join us, and we have also included sustainability in the study. Usually you run a 12-week program for people. Most are motivated, ambitious, participate, and once it's over, the subjects are gone and they stop exercising. And this is why for pain patients, we are focusing on another period of 12 weeks to find out whether people will continue the training, what has changed over time. We, of course, don't leave them alone. They have contacts of rehabilitation centers, vibration board suppliers, and of EMS studios, so they can continue training. What is our aim? We want to end up with 234 participants or subjects. Why so many? Well, pain is very subjective. You will have a lady next a door who will scream when you just touch her, and another person who really has a serious problem in the vertebral column is basically not very susceptible to pain. The second factor, we want to compare 3 different training groups with each other. So the probability that effects are produced in all 3 groups is very high, and this is why you need so many subjects in order to be able to compare all 3 active groups. If you compared it with a passive control group, the sitters, the couch potatoes, then of course with fewer people, effects could be visible. First of all, I will actually introduce you to the meta-analysis of individual patient data. We refer to it as meta-analysis of own data because we've only used our own data. Why? Mr. Wegner already said in the area of orthopedic disorders, you hardly find any scientific evidence. There's some master theses, but nothing that is really providing scientific evidence. And this is why we asked about the pain intensity and pain frequency and filtered these out as pains for for the vertebral column. In this meta-analysis, we actually included men and women with unspecific back pain aged 65 plus. Why are they so old? Because we focus mainly on older people in our research at our universities rather than young, sporty people. Then we filtered this based on frequency on a scale of 7. We actually decided above 5 would be very frequent. So all in all, we've got 45 subjects on the study protocol. There were 5 different studies made with the identical protocol, but the period varies for each and every one. The 14 weeks was the lowest period, up to 1 year. This was the longest period. The EMS protocol was comparable, as I said before, both in terms of intensity and on and off times, and the intensity was the same with hard to very hard. We always trained dynamically, so people were not sitting on chairs. No, slight exercises, a very slight workout was applied that was easy to do for our customer base. What did we find out? Well, 45 subjects could be included in the meta-analysis. Let's first look at the basal characteristic, the basic characteristics. So the average age was very high at 70. As I said, we mainly focus our research on older people, and the pain frequency and the pain intensity was always above 5. So it was a severe pain. At the beginning, there were no significant differences between the groups, which is important, of course, because an identical starting situation must be ensured. When you now look at the results, you always see the delta, the changes, using the 7-stage index, the 7-score index, and in the middle, in the center, you can see whether there were significant differences, yes or no. When you only look at pain intensity with this star, you can see that there is significant differences between the 2 groups. In pain frequency, unfortunately, in science, there is a certain limit value, and this is put at 0.5. And our value stood at 0.51. So this is why we have to say that there was no significant difference regarding pain frequency. But the bars do show a clear difference between EMS and the non-EMS control group. Well, the results already show that there are differences, although the pain frequency only showed a marginal score. All 5 studies for EMS show a very homogeneous change factor, and you can also rate this even further. What you see is the effect as SMD. This is the statistical main difference. It stood at 0.91. When you compare this with conventional treatments such as strengthening, stability, or relaxation and Tai Chi, there's a wonderful meta-analysis by Seal. You can see that the average value stood as 0.32. So EMS fed a lot higher. If you only looked at stability and strengthening, then the value is at 0.5, so still 50% lower than our calculated value. What is negative about this study? Well, it was not a specific clientele for these unspecific back pains. We just looked at people that suffered from back pain. If you want to do it really properly, then you really have to confine yourself to this clientele. You have to cover a certain age group, and then you have test the group and marginalize for specificity. So it is important to do a randomized controlled trial and add this, and I will actually introduce you to it now. In the first stage, the aim was to verify the effects of new training methods, whole body vibration. This is why we've included this whole body vibration, WBV. What was the target group? 40 to 70 years old, unspecific and chronic back pain. The chronification was defined by saying, well, people should have suffered at least 50% of the days from lumbar back pain over the last 3 months. What was the typical exclusion criteria? Well, everything where EMS and whole body vibration cannot be done, like pacemakers or artificial knee joints, hip joints, or drugs that actually influence muscular metabolism or bone metabolism. All of the specific diagnoses were excluded, and it is incredible what is ignored by subjects. I had people who called me and said, well, they have a high degree of stiffness in the vertebral column, and they think that it is an unspecific back pain and nothing has ever been done about their back. And then there were all other comorbidities that would have caused a difficulty in the interventions and would have produced deviations that are unacceptable. And the subjects had to be present all of the time with the exception of 2 weeks. After recruitment, we got 60 subjects, 20 men, 40 women, and they were randomized in 4 different groups. We subdivided them by pain status, so to speak. So we had the same cross-section in all 4 groups. First of all, the EMS group, we had 15 people in this group. It was a classical training that is available on the market out there once a week, 20 minutes, with the usual training protocol. And we did exercises all standing up, squat positions mainly, and with the arm pulleys, back pain and belly exercises were focused. For the whole body vibration training, I don't know whether you've ever done it. You stand on a board and this board vibrates and alternating sides, and standing on the board, the people actually went through a workout, a certain series of exercises, so they also had to do pulling. The training takes place twice a week, 15 minutes, and the various frequencies were used, so every exercise had a different hertz number. Then the classical back strength program, you know it from rehab sports. The difference being that they worked in a circle in order to capture the intensity and make it comparable with the other 2 training protocols. The training, the way it is administered by a doctor once a week for 25 minutes. And there was also the control group that was only expected to live the same lifestyle. You may wonder, why do we compare 3 training interventions that are so different because of the time invest and can actually produce different results? Well, it is simply to establish something that correlates to something you'll find out there on the market. You will never find an EMS training with full exertion lasting for 45 minutes once a week. And nor will patients ever find a back exercise or strengthening program that's only 15 minutes long once a week. So how did we proceed? Well, we relied on a pain diary. The subjects, the participants, could use a rating scale: 0 no pain, maximum pain 10. They could cross and tick boxes describing their pain situation for every single day, and actually also complete this with drug intake or certain activities that could have actually impacted pain. And through this questionnaire, we also found out whether people sit a lot, so we had a lot of background and knowledge. Then a functional test of the muscles took place. You can see there's a strange piece of equipment here. This is an isometric strength measurement device of your belly and your back. 3 trials were done, and the strongest value was measured before and after treatment. And then bioimpedance measurement was introduced. This is a measurement of the composition that not only represents the complete body composition, you can also measure the composition in individual segments of the body: muscle mass, body fat, etc. We wanted to find out whether muscle mass changes at the back. Then primary and secondary endpoint of the study was pain intensity and the strength values. The basal characteristics can be seen here: gender, age, height, intensity. There were no significant differences pre-treatment, and in the pain intensity you can see on the scale of 10 that the average was 4. When you now look at the results, and I have listed all groups here: pain intensity, max and average, you can see that all 3 training groups had highly significant changes for the better. Logically, in the control group, hardly anything changed because they actually retained their lifestyle. In maximum pain intensity, it is very much the same, but there is no significant difference between them and the control group. If you only focus on EMS and the control group, then you can actually subdivide it or break it down into flexion and extension, which is the back strength. Interestingly enough, there was only a significant difference between the subject group and the control group in the extension, whereas in the curl it was not so significant. Why is this probably so? Well, it is possible that the training protocol was chosen that way, that it was to promote the stability of the back muscles, and but you need the complete mass of the 234 subjects to actually identify this. The summary of all of this, well, EMS seems to be a proven method to reduce pain frequency and pain intensity, but we have not reached the right power yet. This needs to be continued even further. Interesting in this context is that the national care guidelines foresee TENS and other electricity-based treatments as a negative recommendation. Why is this so? Well, either they have not done any research yet, or they're probably afraid of any risks. Here you can clearly see that it does produce an effect, so you can use electricity for these clients. In phase 2, we carried this on, but without the control group. So we're only speaking of the various training groups of subjects we're comparing. And 74 new subjects were added, so that we almost had 120 people available. Here again, in the basal entry values, no significant deltas between the groups. Also striking, the pain intensity on average, due to the number of subjects, came down. So we're down from the 4 on a scale of 10. We're now in the region of 2 and 3 on a scale of 10. Results, primary endpoint, the average pain intensity is shown here in the top graph. In all 3 groups, there was a significant change felt. So it produced an effect on all 3 groups. Unfortunately, we cannot say which group actually fared better or worse. This is not possible yet. This is also reflected by the maximum pain intensity, but with different significance. When you look at strength, you can see that both flexion and extension improved significantly, highly significantly. But there's only a trend that can be seen. The red bar, the circle training was a little higher than the other 2 bars, but this is not the final statement yet. Considering other cofactors that you are aware of, because with pain patients you've got many other comorbidities. Then, for instance, mental factors need to be factored in. The RMD, this is the Rowland and Morrison Disability Questionnaire. It includes 24 different questions. Can you walk up stairs without any pain? This is to test all of the various physical functions. And you can see that improvements happen in all 3 groups. And here you can see this best with EMS, but no significant differences yet again. In mental factors, we focused on the German pain questionnaire, and we focused on 7 questions, including, do you feel happy? Are you satisfied with yourself? Everything that revolves around mental issues. And here you can see that slight improvements happened, with the exception of the EMS group. Here you can see it even clearer, but no group really had a peak. Well, I mentioned the most frequently used excuse, and that's the factor of time. And this is why we also looked at the training times, compliance or the tendency, then the number of dropouts, the people who stopped the intervention, and we also looked at whether there were any changes in drug intake or administration. In the attendance rate, we can see that with roughly 92% were particularly well attended, whereas the strength training was only at as low as 87%. So there is a significant difference. So the novel and short training routines obviously motivated people more than the standard 45-minute training. The same applies to the dropout rate. 7 dropped out from the strength training, whereas only 3 and 4 actually dropped out from EMS and the whole body vibration. If you then look at drug administration, because the aim is, of course, to bring down the amount of drugs or painkillers administered, you can see that in the EMS area of 13, only 7 required drugs. In the vibration group, there was no change. And in strength training, the number came down from 10 to 5. If you look at the efficiency, the training times, Here, EMS, of course, stands out, and vibration with 15 to 20 minutes. For people who have very, very little time, these two training routines are far more attractive than 45 minutes once a week. People are thinking of a whole hour when we speak of 45 minutes, and 1 hour can be a lot of time. So what is my take-home message? Despite the trends in the individual groups, you always have to factor in the conditions, the circumstances. Conventional programs seem to produce better effects, but the time factor, the factor of time, plays an important role, and actually accounts for the slightly lower effect. Summary: it looks as if all three types of routines produced high effects, but there is not a single one that is outstanding. They're just trends. So absolute power. So 78 subjects per group. The absolute power is still missing, but it will be achieved towards the end of 2018, early 2019. And then we can clearly say whether novel training routines are better than traditional offers. In this particular case, sustainability should be mentioned as an important term. When you see that EMS produces a high effect, many people do it, but EMS is still quite expensive, and for rehabilitation you would get a free prescription. The question is, would people continue doing it despite the costs? So after, again, 12 weeks, we will want to know from the subjects, will you continue, or do you still continue your activities? Has your pain status changed again? And would you like to continue it if it was free of charge? You know from yourselves, whenever you've received something for free, it is very hard to start paying for it, although it may be very beneficial. It sounds paradoxical, but this is how people obviously work and act in our healthcare system. So much for me. Thanks very much for your attention, and have a wonderful day at FIBO.